Okay, well, good afternoon, good morning, everyone. It looks like we were just waiting a couple minutes for folks to keep dialing in, but it looks like numbers have slowed down a bit. So we're going to go ahead and get started. Again, good afternoon, good morning. My name is Katie Moore with CMS, and we are going to cover an overview of the 2027 Quality Payment Program proposed policies that were just recently released in the 2027 Physician Fee Schedule proposed rule. So if that is not what you were looking for information on today, you may be in the wrong place, but hopefully everybody is where you were intending to be this afternoon or this morning if you're on our West Coast time. We can go to the next slide, please. I think we can go one more. Great, thanks. Well, we really appreciate everyone taking the time to join us today. I know we always have a really wide range of participants on these calls, from our clinicians and participants in the program to specialty societies and advocacy organizations. Sometimes we have patients, and then all the different important support staff that help clinicians be able to do what they do and to take care of Medicare beneficiaries across this country. So we really appreciate all that you all do to contribute to our healthcare ecosystem and make sure folks are getting the best possible care that they can. So today we are going to cover, I'm going to go through just a few slides to start with that will cover a summary of just what QPP is and overview of MIPS. So first few slides will probably be for folks that if you're new to this program or working with us at CMS, this will just be some new information, but just some basics about the program as a whole. But for folks that have been working with us for years now, it'll just be bear with us while we kind of cover just the basics to level set before we get into our proposals. So we'll cover updates that have been made to our MVP, so MIPS Value Pathways. We'll cover each of the performance categories, so quality, cost, improvement activities, promoting interoperability. We have some minor final scoring updates, and then we'll cover third-party intermediaries, changes there for our QCDRs and registries. And then we also have, so we have all different parts of CMS. So we've got our CMMI Innovation Center colleagues to talk about advanced APMs, and then we'll have our Center for Medicare colleagues talking about our shared savings program, but all part of our bigger quality payment program. And then we do have several RFIs that will discuss what we're looking for to continue partnering and getting feedback from everybody. And then we always wrap up kind of with our resources and where you can go to get more help and support, and very importantly, how to submit comments through the formal rulemaking process. So I'm going to throw out the date of the deadline. So Monday, September 14th. We'll probably say that several times today, but we really need, we'll have as much time as we can at the end for questions and comments from folks. And we really appreciate folks dialing in and entering questions in the Q&A. But what is really critical is to have those comments submitted formally to CMS. And we'll have a slide towards the end that gives you all the details on how, where, when to do that. But Monday, September 14th is that magic date for a deadline where we need to receive all of those comments for consideration. And I just want to point out a couple housekeeping things. We do have a Q&A function. So as we're going through our different presentation slides today, feel free to enter questions in the Q&A. We'll try and save as much time as we can at the end to take some questions live, or if we see recurring questions or themes, we'll try and have our SMEs come off mute to talk a little bit more about those different topics. We do have a large number of CMS staff on today, so you've got a lot of pretty much all the experts in the room for all the proposals you hear about today. So definitely take advantage and put those questions in there, and then we'll answer them throughout. But then we'll save some time for the end. And I know we already had a question about slides and transcripts and recordings. So just to say again that those will be available in the coming weeks. We always post them on our webinar library on qpp.cms.gov. So keep an eye out there and on our listserv for when those resources become available. And then just throughout today's discussion, we'll be putting in the chat helpful links. Appreciate our team for doing that throughout, so we don't have to remember to do it while we're talking. But so just keep an eye there for links for different things that we're talking about, especially our overview fact sheet that has the links already in the chat. Okay, next slide, please. One more. And one more reminder is that today I know folks might have questions about either current performance category or performance year, sorry, current performance year questions or things outside of 2027 proposed policies, but we're really trying to keep the focus of today since we only have limited time and have a lot of information to cover, to really keep those questions and comments focused on the proposals that were just released. And towards the end, we'll have more slides on where to go if you have questions that are outside of our proposals, because we have some wonderful service center agents available to help work through either current performance period questions or feedback questions or anything else outside of what we're talking about today. So just wanted to make sure that those resources are available and just set expectations for what we will focus on today. Okay, so with that, just a few overview slides about the Quality Payment Program here. So the Medicare Access and CHIP Reauthorization Act of 2015, what we lovingly refer to as MACRA, ended the sustainable growth rate formula, which would have really resulted in some significant cuts to Medicare payment rates for clinicians. So Congress got together, created this new program called the Quality Payment Program. And what MACRA, what the legislation really was trying to do was take all these different fragmented programs that were really siloed and not connected and put them in a more coordinated framework. And that is where the Quality Payment Program was established. And there are two main participation tracks in the Quality Payment Program. So the first one is the merit-based incentive payment system, so MIPS, and then the second is advanced alternative payment models or advanced APMs track. Next slide. So focusing on the one track, MIPS for right now, this is very high level about the program. So again, please check out our website, qpp.cms.gov, for all the details you could possibly want on all of the different performance categories and detailed information you might want to receive. So basically, for MIPS, you collect and report measure and activity data for 4 performance categories. So quality, improvement activities, promoting interoperability, so sorry, 3. And then the 4th performance category, cost, we as in CMS, collect and calculate that data for you if it applies to you. So then across your performance is assessed across those 4 performance categories, and you receive a final score, which is 0 to 100 points. And then your final score, this is what determines whether you receive a negative, neutral, or positive MIPS payment adjustment. So we take that final score and compare it against a performance threshold, which for 2027, which is the performance year we're talking about today, the performance threshold is 75 points. So for clinicians that achieve above 75 points, receive a positive payment adjustment. At 75 points, neutral, and below would be a negative. So when we're talking about today, we're mainly talking about 2027 performance year, which corresponds to the 2029 payment year. So how folks do in 2027 performance will determine what their Medicare payment adjustments, Medicare Part B covered professional services, what their payment adjustment is in 2029. Next slide. So while QPP does consist of those 2 participation tracks, there is overlap between the 2. So we put together this graphic to kind of visually help explain that overlap. So clinicians that are participating in advanced APMs are not automatically um, participating in the advanced APM track. They have to achieve this qualifying APM participant status or QP status. So if QP status is achieved, clinicians are exempt from MIPS. If partial QP status is achieved, they have the option to participate in MIPS or not. And then if they are in an advanced APM but do not achieve QP or partial QP status, then they get put into MIPS and will be required to participate through that participation track. Next slide. Okay, so just to cover at a high level, so our key QPP proposed policies, really the focus overall is moving MIPS into the future for full implementation of MVP. So we've been talking about this for some years now, and really excited where we are with MVPs, and we'll talk some more about that in a few slides. But really trying to keep our focus on prevention and wellness. I know you've heard a lot of these high-level topics throughout the agency. So really focusing on prevention and wellness, burden reduction, so that clinicians can have as much time as possible to focus on their patients and aren't burdened with a lot of administrative requirements from CMS in general. And then meaningful participation. This is really important and really what was driving us towards moving towards MVPs. Um, and when we say meaningful participation, we mean, what makes sense for different types of clinicians to drive value and improvements in health. And then also meaningful participation data for patients so that they can make the most informed decisions possible with the data we have available. And then a few other things that we are requesting your feedback on. So we put out three different requests for information. The first one we're really excited about is a lot of movement you've been hearing about towards digital transformation. So we have put out in this RFI a timeline for how we want to see. We're proposing to see implementing Fire-based digital quality reporting. So a lot of questions around there that we need some feedback on. MVP scoring methodology, and then lastly, star rating assignment methodology. So this is for our publicly reported administrative claims quality measures. Next slide. So some key proposals. This first one, again, we've been working towards this goal for some years now. I know we've had a lot of conversations with a lot of folks on the call today. So thank you, everybody that has been on this journey with us to develop MIPS value pathways that are really meaningful to the different types of clinicians and specialties that participate in our program. But we have proposed to sunset traditional MIPS starting or after calendar year 2028. So what this means is that beginning in calendar year 2029, MIPS MVPs would be the only MIPS reporting option available, unless a clinician is eligible to report through the APM performance pathway or APP. So in that same movement, we are introducing 3 new MVPs this year. You'll hear some more about those in a few minutes. So that'll bring us to a total of 30 MVPs available. We are proposing a MIPS core measure requirement. So this is going to replace, currently we have requirements for outcome and high priority measures, and then this core measures change will replace that for the quality performance category. For promoting interoperability, we have some revisions proposed to the reporting requirements. And then you'll hear from our CMMI colleagues about proposals to make a change to apply the QP determinations at the TIN NPI level. And then also some updates to the QP and partial QP thresholds and APM incentive payment. And that is all a result of the Consolidated Appropriation Act of 2026. Next slide. And then we'll have our Center for Medicare colleagues talking some more about Medicare Shared Savings Program proposed policies. First, extending the availability of MIPS CQM, so clinical quality measures collection type, and the MIPS CQM reporting incentive for our shared savings program accountable care organizations that report the APM performance pathway, so APP plus quality measure set for 2027 and then subsequent years. A proposal that all measures that are reported through the Medicare CQM's collection type would be scored using flat benchmarks for 2027. And then some other technical changes there for flat benchmarks that you'll hear more about. We are also proposing to address ACO's challenges. We know we've heard a lot, we hear a lot and have lots of discussions with ACOs on meeting MIPS data completeness requirements. So we're making some proposals that hopefully will address those challenges. And then lastly, modifying our shared savings program CERT use requirements, so certified electronic health record technology requirements. And then again, seeking some comment on how to apply the electronic prior authorization measures to ACOs participating in Medicare Shared Savings Program, so for future years. So again, looking for lots of feedback through formal process. That comments are due September 14th. Next slide, please. Okay, and with that, I'm going to hand it over to Michelle Peterman, who's going to walk us through more details on our MIPS Value Pathways proposals.
Thanks, Katie. Hi, everyone. So for this next piece, we're going to be talking about our proposed MVP development and maintenance policies for 2027. So on this slide for 2027, we are proposing 3 new MVPs, entitled Diabetic Disease MVP, a Hospitalist MVP, and a Hypertension MVP. The Hospitalist and the Hypertension MVPs aim to establish a reporting pathway for hospitalists, nutritionists, and dietitians who previously lacked an applicable MVP for reporting. Additionally, the hypertension and diabetic disease MVPs target chronic illness prevention, which provides focused interventions and evidence-based care for high-risk groups. For the MVP modifications, we are proposing modifications to all 27 existing MVPs. This was in order to identify MIPS core measures for each MVP. This is in alignment with the MIPS core measure proposals, which will be discussed a little more depth during the quality portion of this webinar. So for the current 27 MVPs, 23 have updated measures and improvement activities that are meant to enhance clinical concepts, promote health, address maintenance requests, or replace outdated measures with stronger ones. And then our final modification we are proposing is to rename the Rehabilitative Support for Musculoskeletal Care MVP to Rehabilitative Support MVP so that the title better reflects the measures and activities included in that MVP. So if these policies are finalized, that will bring us up to 30 MVPs available for reporting in calendar year 2027. At the bottom of the slide, there is the Explore MVP tool on the QPP website. We encourage you to review all the new and updated MVP proposals there. Next slide, please. So for MVP implementation, as Katie noted earlier, we have proposed that the traditional MIPS reporting option will end after the calendar year 2028 performance period. That means starting in calendar year 2029, MVPs will be the only MIPS reporting option for clinicians not eligible for the APP. Allowing this, we're proposing this now to allow clinicians time to prepare for this transition. Clinicians in the MIPS APM will be able to continue to report the APP at the individual group or APM entity level. Next slide, please. In coordination with the sunsetting the traditional MIPS reporting option, we're proposing that virtual groups would be able to report an MVP beginning with the calendar year 29 performance period. Again, we're proposing this now so that clinicians may have time to prepare for the change. And that wraps all of the MVP policies for maintenance and development. I'm now going to pass the presentation over to my colleague, Pam.
And actually, it's going over to Dr. Dan Green.
Thank you. Welcome, everybody. Next slide, please. Thank you. So we're going to talk about the quality performance category and what we're proposing with respect to the measure inventory first. So we are proposing to add two MIPS quality measures that focus on prevention and chronic disease management. One of these measures, however, we are proposing a delay in implementing. So we're proposing it now, but we're planning to implement it, again, assuming we receive favorable support in the calendar year 2028 performance period. So it would not be a MIPS 2027, but again, we did put it in the rule to solicit feedback. There are 9 QCDR measures that we're proposing to actually qualify as, instead of QCDR specific measures, MIPS CQMs, which means they would be broadly available to everybody who provide services in the denominator or have patients with diagnoses in the denominator. There were 43 substantive changes to existing quality measures, excuse me, and we removed 20 quality measures from the quality measure inventory. This would leave us, when we do all the math up above, with about 180 quality measures for the 2027 performance period. Now, please note that does not include QCDR measures in the numbers that I've listed from above. Next slide, please. So as Katie mentioned earlier, we are proposing to remove the high priority measure designation. We are proposing to remove the requirement that MIPS eligible clinicians have to report at least one outcome measure as one of their required measures or a high priority measure. So that's what currently is required. Again, we are proposing to remove that. Next slide, we'll get into it. As Katie said, we are talking about and proposing MIPS core measures. So these would be measures that are found in MVPs as well as traditional MIPS. The idea here, at least in MVPs, is to try to either highlight measures that may be more important or relevant to a particular specialty, but also have allow for more direct comparison between clinicians. I mean, currently docs can report a hodgepodge of measures. That's part of the purpose of the MVP, and I think further aligns with our proposal for the core measures. So again, we would ask that clinicians report at least one core measure in lieu of the outcome or high priority measure that was previously required. Now, small practices would be exempt from the MIPS core measure reporting requirement. Next slide, please. Okay, so I am going to turn it over to Zenobia for some scoring discussion.
Thanks, Dr. Green, and good morning. Good afternoon, everyone. So jumping right in where Dr. Dan left off, there are, in alignment with the MIPS core measure requirement, that measure will be scored a 0 if that measure goes unreported. In cases where folks submit an attestation that they didn't have an applicable core measure and submit another core measure in its place, that measure will still be scored, meaning the only exemption for the MIPS core measurement is if those conditions are met. And additionally, small practice will not be scored 0 points for not submitting a MIPS core measure. The next scoring policy is regarding the defined topped-out measure benchmark. As a refresher, the defined topped-out measure benchmark is the benchmark that scores select topped-out measures from 1 to 10, meaning these measures do not have a 7-point cap applied, as is typical for topped-out measures. In this year's rule, we're proposing 17 measures to have this defined topped-out measure benchmark applied that are impacted by limited measure choice in the specialty measure sets. Additionally, any MIPS score measure that is topped out will also have the defined topped out measure benchmark applied, meaning that any MIPS score measure will be able to be scored from 1 to 10, topped out or not. Next slide, please. Lastly, for the APP quality measure set, we are proposing the removal of 2 previously finalized measures, initiation and engagement of substance use disorder treatment and adult immunization status. With those proposed removals, that would bring the APP quality measure set to a total of 8 measures starting in 2027. Next slide, please. Now Katie is going to walk us through the proposals in the cost performance category. Thanks.
Great. Thanks, Zenobia. So not too many proposals here for cost this year. So we are proposing to update operational list of care episode and patient condition groups and codes. These are just really maintenance updates that are non-substantive for the measures. And the operational list, I believe, was posted along with the proposed rule for public comment. So please take a look at the operational list. And then next slide is just saying that we can go there. There we go. That we are not making any, we do not have any proposals this year for changes to our cost measure inventory for 2027. Thanks. I'm going to turn it over to Will Kay to cover our improvement activities performance category updates.
Thank
Thanks.
you. And good afternoon, everyone. So for the improvement activities category, we are proposing to add 6 new activities, modify 5 existing, and remove 11 activities. The new activities are both in the care coordination and advancing health and wellness subcategories, and there's an emphasis on prevention, as well as a new improvement activity for the use of artificial intelligence to improve patient care. So the 6 new improvement activities are in the care coordination subcategory: use of data to improve practice workflows, understand and improve diagnostic performance. And then in the advancing health and wellness subcategory, systematic screening and intervention for nutrition and other health impacting non-clinical issues, advanced care planning conversations to support health, patient wellness and care preferences, and then finally the clinician use of artificial intelligence to improve patient care. So that's it for improvement activities, and I'm going to pass it over to my colleague Lisa Marie for the promoting interoperability category. Thank you.
Thanks, Will. So I'm going to discuss our proposals relating to promoting interoperability. Our first proposal relates to the proposal to modify the definition of CERT. And with this proposal, we're proposing to remove 5 elements from the definition. The first is the family health history. The second is the patient health information capture. The third is the automated numerator recording. The fourth is the automated measure calculation. And the fifth is the clinical quality measure filter. Next slide, please. We're also proposing to remove requirements from the promoting interoperability performance category. The first 2 proposals that we're wanting to remove requirements relates to the ONC direct review attestation and the ONC ACB surveillance attestation. So for the performance period 2026, we're proposing to remove those 2 attestations. So that means for currently our performance category that we're currently in, which is 2026. So when you're going to be reporting for 2026, which is in early 2027, we're proposing that these attestations would be removed. We're also proposing to remove the security risk analysis measure, and this is specific for starting with the 2027 performance period. Next slide, please. We're also proposing to make modifications to the electronic prior authorization measure. And the ways that we're doing that are as follows. So the first way is that for the 2027 performance period, we're proposing to make this measure a bonus measure or an optional measure, and it would be worth 10 points. We're also making changes within the measure, which would require, so if you do report it, you would be required to use cert that includes Health IT modules certified to at least one of the 3 electronic prior authorization criteria to complete at least one prior authorization request for at least one medical item or service, excluding drugs. So for 2027, we're only proposing that it would be an optional bonus measure for one performance period. We're proposing that starting with the 2028 performance period, the measure would be required, and it would require the use of cert that includes Health IT modules certified to all 3 ONC electronic prior authorization criteria. And again, it would be starting with the 2028 performance period in which it would be required. So by us making it a bonus measure, an optional measure for the 2027 performance period, we believe we're giving folks extra time to prepare for the measure implementation. Next slide, please. Please go back one slide. We're proposing a new measure. It's electronic prior authorization for prescription drugs. So we're proposing for this measure to begin starting with the 2028 performance period. And this new measure would require the use of cert that includes Health IT modules certified to ONC's electronic prescribing and real-time prescription benefit criteria, which rely on the National Council for Prescription Drug Programs standards to complete at least one prior authorization request for prescription drugs and medication starting, again, with the 2028 performance period. Just want to note that this particular proposal for this new measure aligns with the proposals in the 2026 CMS interoperability standards and prior authorization for drugs proposed rule. Next slide, please. Now I'm going to turn the presentation back to Katie.
Great. Thanks, Lisa Marie. Next slide, please. I know this section is titled Final Scoring, but it is really focused on 2 updates that we proposed around operational changes that would impact our a couple different reweighting policies that do ultimately impact folks' final score. But so the first one is related to our MIPS automatic extreme and uncontrollable circumstances reweighting policy. So currently there is language in regulation that requires us that we specify that we will use data from PACOS as our source for determining if a clinician is located in an area that is having the automatic EUC applied to them, which reweights all performance categories to 0, and clinicians receive a neutral payment adjustment. And typically this is related to natural disasters, or we've applied it for public health emergencies in the past. So we want to give the agency as much flexibility as possible to be able to use the most current and accurate data source that is available. So we're just removing that specification. Doesn't mean we won't use PACOS. It just means we have the flexibility to use other sources if it seems like they are more accurate in determining where a clinician is practicing. And I'll go ahead and plug. If you haven't updated your PACOS data in a while, please go in and check that out. And then the second one is related to our third-party intermediary policy that allows clinicians to let CMS let us know that their third-party intermediary or TPI did not submit data for them during the data submission period. So currently, clinicians have until November 1st to notify CMS, and we're just extending that deadline to December 31st of the data submission year so that we're aligning with other policies. So just giving folks more time to let us know if there's an issue in that area. Next slide. And then this is just more information on on how payment adjustments will work for the coming years. Next slide. And I'm going to hand that over to John Jenkins to cover third-party intermediaries.
If I can ever get myself off mute. Wow.
Did great.
Thanks, Katie.
Step.
So now we're going to talk about third-party intermediaries. So we have a few policy updates that we have listed in there. The first one that comes to mind is the performance feedback policy. Basically, there's been some confusion about how CMS has been defining clinicians and groups. So we are going to make it more specific by changing that to with individual clinicians, groups, virtual groups, subgroups, and APM entities. That should clarify the performance feedback that needs to be provided at each level in which the data was submitted. Our second one will be changes to qualified posting. So we're proposing that if a third-party intermediary has changes in information, this qualified posting may not be updated for the public, even if the information is provided. The short version of that is sometimes we get requests to make updates outside our normal schedule, and it is becoming extremely burdensome. And so we decided to start holding them until we have the next scheduled posting. Next slide, please. All right, third-party intermediaries with fewer than 10 QPP participants. We're proposing to clarify that if QCDR or qualified registry submits MIPS data to CMS for fewer than 10 QPP participants, the data validation audit sample must include all QPP participants to ensure that the data submitted are true, accurate, and complete. So I know we have a 25 minimum to get started, but if you only actually submit data for 10, we need the data validation audit sample to include all 10 of them. Additionally, so if we have participants with fewer than 5 patient records, so the 25% of patient record sample, fewer than 5 patient records, the patient record audit must sample, or the sample must include all patient records to ensure the data submitted are true, accurate, and complete. So on that 25% floor for patient records, if it ends up being fewer than 5 patient records, the patient record audit must include all patient records. Next slide. Participation plans. So we're proposing that third-party intermediaries be required to submit a participation plan with their self-nomination if they don't submit data for the year preceding the applicable self-nomination period. A lot of words to describe during the self-nomination period, the previous year, nothing was sent in as far as data. That does happen occasionally. Sometimes it takes a year or so to get to that point. But at this point in time, we need to ensure that there is a clear path that the third-party intermediary has to ensure that they're getting back on track and able to submit data in future years. So the examples you see below, 2028 self-nomination period, it's going to be July 1st, 27 to September 1 of 27. The data submission period for 2026 is January 2nd, 2027 to March 31st of 27. Now, so we have a qualified registry over here approved to submit data for the calendar year 2026, but you didn't. So you would be required to submit a participation plan if you're self-nominating for the calendar year 2028 performance period. And all that is just making sure that you've got a plan to ensure that you're going to get data in to go with your self-nominated status. Next slide. Termination. We're proposing that third parties with a participation plan would also need to provide CMS with documentation they have contracted with QPP participants who will submit MIPS data for the given MIPS performance period. If the documentation can't be provided by the date specified by CMS, third-party intermediaries would be terminated. So if you have not submit for a year and you don't fill out that participation plan that I mentioned previously, CMS is likely to terminate that third-party intermediary. Next slide. And I guess I will pass it off to Julie.
Thanks, John. Now I will discuss what's being proposed. We are proposing to simplify public reporting by removing the requirement that we would not publicly report the first year of data for any new improvement activity or promoting interoperability measure for clinicians participating through the MVP reporting framework. Under this change, this performance data would be publicly reported in its first year for MVP participants, just like it is for other MIPS participants. We're making this change because annual consumer testing consistently shows that patients and caregivers find new improvement activity and PI information clear and useful for decision making. Removing this requirement supports our goal of providing understandable and reliable performance information on the compare tools. If finalized, we would return to our original policy from 2018, where we will publicly report eligible new improvement activities and PI measures the first year they are added for all participants reporting them. Now I'll turn it over to Trevi.
Thank you so much, Julie. All right, so you just heard about the MIPS proposals. The second track of the Quality Payment Program is an incentive structure for participants in advanced APMs. Clinicians in these models who meet certain APM participant thresholds, so payment amounts or patient counts, become qualifying APM participants or QPs for that year. And as such, they receive payment incentives instead of participating in MIPS. I'll cover in the next two slides this payment incentive structure. So historically, QPs and partial QP status has been applied at the NPI level. Note that NPIs typically reassign their billing rights to more than one TIN, and it's common that not all of their TINs are participating with an advanced APM. And so what this means is that because we apply the incentives at the NPI level, we have financial incentives flowing to TINs that are not part of an advanced APM. So our proposal for this year is to update the way we apply QP and partial QP status, and to do so at the TIN NPI level. We think that this has a few advantages. One, it structurally aligns the incentives with participating in these advanced APMs, and two, it aligns Quality Payment Program as a whole. MIPS is a TIN NPI payment structure, and so too would the incentives for QPs. So we can go to the next slide, where we also wanted to highlight another piece of our rulemaking this year. We're proposing to update the QP thresholds in alignment with the Consolidated Appropriations Act of 2026, which updated the way the thresholds exist for performance year 2026, payment year 2028. So that's this year. The thresholds last year were at 75% for payment amount and 50% for patient count. This year, they'll drop back down to 50% and 35% respectively. And then next year, we expect they're scheduled to go back to 75% and 50%. So we wanted that to be clear to this audience. So here they are in table form. That's it from me from the Advanced APM desk over to the Medicare Shared Savings Program.
Hey, thanks, Trevi. This is Sabrina Ahmed, and I'll be reviewing the Shared Savings Program proposals that are included in the 2027 PFS proposed rule. These proposals are aimed to reduce burden and also support ACOs in the transition to reporting digital quality measures. As described on slide 47, we propose to extend the availability of the MIPS CQM collection type for ACOs reporting the APP plus measure set beginning in performance year 2027, and to continue to align the MIPS CQM reporting incentive with the extension of the MIPS CQM collection type. We also propose to extend the MIPS CQM reporting incentive to ACOs reporting MIPS CQMs in performance year 2027 and subsequent performance years. Next slide, please. Beginning in performance year 2027, we propose that all measures of the Medicare CQM collection type would be scored using flat benchmarks. Additionally, we propose that 3 measures, which are quality ID 001, 134, and 236, if reported via the Medicare CQM collection type for performance year 2026, would be scored using flat benchmarks. Under current policy, these 3 Medicare CQMs would have been scored using benchmarks based on historical data. We also propose several policies to address ACO's challenges with meeting the MIPS data completeness requirement. And the first of these policies is that beginning in performance year 2027, we propose to revise the definition of a beneficiary eligible for Medicare CQMs to align with the population of beneficiaries assigned to the ACO. Next slide, please. The second policy we proposed is that beginning in performance year 2027, we propose to establish the Medicare eCQMs as a new collection type for Shared Savings Program ACOs reporting the APP plus quality measure set. A Medicare eCQM is essentially an eCQM that's part of the APP plus quality measure set and would be reported by an ACO on only its assigned beneficiaries. Medicare eCQMs would generally follow the eCQM measure specifications. However, they would be reported on a different population and use a different identifier to distinguish that the submission is for a Medicare eCQM rather than for an eCQM. We also propose that measures of the Medicare eCQM collection type would be scored using flat benchmarks beginning in performance year 2027. We note that ACOs that choose to report Medicare eCQMs would not be eligible for the eCQM, MIPS CQM reporting incentive under the Shared Savings Program or the Complex Organization Adjustment under MIPS. Next slide, please. The final policy we propose to address ACO's challenges with meeting the MIPS data completeness requirement is to revise the Shared Savings Program quality reporting requirements beginning in performance year 2026. So for performance years beginning on or after January 1, 2026, we propose that ACOs may exclude one or more ACO participants from its submission of eCQM, MIPS CQM, Medicare CQM, or Medicare eCQM data for each measure if certain exclusions are applicable. And these applicable exclusions include unforeseen circumstances that are outside of the control of the ACO, such as the unexpected closure of a group or individual's practice that bills under the ACO participant TIN. The ACO participant TIN has a cert that's intended for specialty use and does not support the measures included in the APP plus measure set, and also other circumstances as determined by CMS. In addition, we proposed that after the exclusion of the ACO participant TINs, the ACO submission of data for each measure must include ACO participants that represent at least 95% of the beneficiaries assigned to the ACO prior to the application of the measure specifications. Under this proposal, ACOs would still be required to meet the MIPS data completeness requirement for each measure for which the ACO submits quality data to CMS. Next slide, please. We also propose to revise the Shared Savings Program scoring policy for excluded APP plus measures and APP plus measures that lack a benchmark, specifically beginning in performance year 2027. We propose to revise the scoring policy under the Shared Savings Program to apply the higher of the ACO's quality score or the equivalent of the 40th percentile MIPS quality performance category score if 4 or more measures in the APP plus quality measure set are excluded from MIPS. We also propose that the scoring policy would no longer apply when at least one of the required measures in the APP plus measure set does not have a benchmark beginning in performance year 2027. Next slide, please. As stated previously, during the discussion of slide 22, we propose to update the APP plus quality measure set, which is the quality measure set that Shared Savings Program ACOs are required to report. We propose several changes to the measure set, including the removal of 2 previously finalized measures, quality IDs 305 and 493. Next slide, please. Slide 53 introduces the changes we proposed for the Shared Savings Program CERT use requirements. These proposals would be applicable beginning with performance year 2027 and would be applied at the ACO level. These proposals are intended to support ACO's transition to digital quality measurement while recognizing and giving credit to ACOs for steps that they're already taking. We'll provide more details about the CERT use options for ACOs on the next slide. So in addition to the proposals we made for performance year 2027, we announced in the proposed rule that we will exercise enforcement discretion for Shared Savings Program CERT use requirements for performance year 2026, as we did for performance year 2025. So this means that we will not take compliance action for any of the ACOs that do not meet the current Shared Savings Program requirement to report MIPS PI measures and activities or the associated public reporting requirement for performance year 2026. There is an FAQ linked on the resource slide at the end of this presentation where you can find more information on this Shared Savings Program enforcement discretion. We note that the Shared Savings Program PI enforcement discretion does not impact the MIPS program's PI requirements for MIPS eligible clinicians participating in the Shared Savings Program. CMS is using its enforcement discretion in regard to only the Shared Savings Program PI requirements. Also, in the Shared Savings Program CERT use section of the proposed rule, we're seeking comment on applying electronic prior authorization measures to Shared Savings Program ACOs in future years. Next slide, please. So on slide 54, we have the 3 proposed options for ACOs to meet the Shared Savings Program CERT use requirements beginning in performance year 2027. The first option is for ACOs to report at least one of the 5 ACO reported measures in the APP plus quality measure set through either the ECQMs or the newly proposed Medicare ECQM's collection type, and meet data completeness requirements. So ACOs reporting through the ECQM or the Medicare ECQM collection type would not need to complete an attestation because we would be able to discern that ACOs reported via one of these collection types. The second option an ACO could select would be to attest to having used FHIR capabilities in their cert to support complete reporting of at least one of the 5 ACO reported measures in the APP plus measure set. And for ACOs using FHIR capability in their cert to support complete reporting of a measure via the MIPS CQM or Medicare CQM collection type, an attestation would be required for the purpose of meeting the Shared Savings Program cert use requirement. The third and final option ACOs would be able to select to meet the Shared Savings Program cert use requirements would be to attest to one of the 3 ACO level cert use metrics we proposed. The metrics from which ACOs could select would be similar to the 3 metrics in the MIPS PI performance category, but these ACO cert use metrics would be attested to at the ACO level and would have specific allowable exclusions. The metrics fall into the categories of electronic prescribing, health information exchange, and provider to patient exchange. So this is the end of the presentation on the Shared Savings Program proposals. I will now hand it off to Katie Moore. Thank you.
Awesome. Thanks, Sabrina. Okay, we're almost to the end, so bear with us a few more minutes, everybody, and then we'll get to some Q&A. But again, here just some more detailed information on those 3 RFIs that I request for information that I had mentioned earlier. So the first one is around FHIR transition timeline. We have questions in there about key milestones and implementation considerations, and other questions around what barriers folks might be facing, just to help us make that transition happen as smoothly as possible. Again, around MVP scoring methodology, just looking for some feedback on how we could facilitate making sure that we're having appropriate comparisons between clinicians that are participating in the different MVPs. So no proposals. I think we may have had a question in the QA about what some proposals this year. So no MVP scoring methodology proposals around this year, just some questions on consider things we might need to take into consideration for future years. And then lastly, but not least, star ratings assignment methodology. So just looking for some feedback on improvements and some alternative options there. So yep, again, look forward to as much feedback as folks have. I know especially in QPP and I think CMS as a whole, but we really appreciate feedback when we're trying to think through some difficult policy scenarios so that we can have the best, most efficient and effective policies possible around a lot of different topics. So appreciate that feedback on the RFIs. Next slide. One more. And this is just a list of all the different resources we have available. So we've got the QPP fact sheet. It has a really great comparison table that shows current 2026 policy and how that policy is changing for 2027. We put out a proposed and modified MVPs guide. So that really helps you to submit comments on the different proposed MVPs, and then plug for our Explore MVPs tool that is on the QPP website. So just reference for the QPP website as a whole, if you are not familiar with it or haven't used it as much in participating with the program, I really encourage folks to check it out. It has a lot of great resources throughout, some really wonderful tools like our lookup tool. You can find out what you are eligible to participate in, explore MVPs and our measures and improvement activities, search function as well. So just encourage you to check those out. And then we have an updated, just a graphic of a transition timeline from traditional MIPS to MVPs. This isn't necessarily new. You've seen it before in previous rules, but it is updated with the new sunsetting information. And then I know Sabrina just mentioned SSP team has a really great fact sheet and some FAQs around their proposals, so check those out. And then lastly, just another graphic of the transition timeline that is discussed in the transition timeline for Firebase, digital quality measurement and reporting. It's just the same graphic that is found in the rule itself, just kind of pulled out separately so folks can see that. And then coming soon, we're working on an MVP transition toolkit for small practices, because we always when we can, really like to tailor resources, because we know small practices are facing some different challenges that other practice sizes may not face. So try to have as much resources available for those folks as well. So keep an eye out for that. Next slide, please. One more. Oh, yep, there we go. And then as I've mentioned a couple times, we really do need that formal feedback. September 14th, and this slide just explains the different ways that you can submit feedback to CMS electronically. Is typically what most folks do, is usually the easiest, but we also take regular mail, express mail, and I know September 14th seems like it feels like it's a good distance away, but it sneaks up pretty quick. And do request, plead for folks to submit comments as early as you are able to. It really helps us to get those thorough responses out and keep things moving. As soon as you can get those comments in, we really appreciate that. Next slide, please. And then, as always, we have a wonderful, wonderful quality payment program service center. Agents are available to answer questions, whether about current participation in the program, or basically anything about the program. This is your way to get those questions answered or directed to CMS for more information. So encourage you to contact folks there. And then I think the next slide should go into Q&A. Okay, yep, that wraps up our presentation. So real quick here on logistics for the Q&A session, we will answer as many as we have time for. We can take questions live. We're gonna comb through the Q&A, and I know folks have been looking at that on our side throughout, and try and pull out some questions if we're seeing multiple of them. So we'll go back and forth between the QA box, and then if you want to speak, I see some hands up already, so that is great. Just go ahead and use the raise your hand function, and then our moderator will unmute your line, and we can take your questions live. I think that is it. Yep, so we'll go ahead and get started. And sometimes we get questions on here that are a little more complex or very specific, so we may need to take that back and follow up with folks offline. So just heads up there. But okay, let's go ahead and get started. Let's see. Who we can take a question. Sorry, I'm gonna ask Jackie, our moderator, if there's
Yes,
a way to
I
tell who's
unmuted.
okay.
Yeah,
Thank you.
I unmuted the first person, so you're able to ask your question now.
Hi, good morning, everyone. Thank you for the insightful webinar. The
Oh,
question I
Vinia,
had,
real quick, sorry to interrupt. It's Katie Moore again at TMS. Real quick, if folks can just say their name and either what organization they're with or type of clinician, that's super helpful. Thanks.
absolutely. Hi, everyone. My name is Vin Sharma. I'm calling from UCLA Health in Los Angeles. My question is related to the MSSP program. Is there a complete financial methodology paper or RFA or practice agreement available anywhere on the CMS website? That is the one single biggest barrier we're seeing, that we can't find a complete financial methodology paper on the MSSP yet.
Hi, so we don't have our finance colleagues on the line today, but would you be able to send your question to the Shared Savings Program and
I did that already, but I haven't heard back yet. But I can resend it again. No worries.
okay, that would be great. Thank you.
Yeah, thank you. And then I have a related question as well, if you will, related to MVPs. One of the other confusions we have is there are measures which are ECQMs, there are measures which are CQMs, and then QCDRs. I was hoping to get some clarification on how are QCDR measures any different from the CQM measures, because what I'm seeing is that both of these category of measures, we generally work with a third-party registry to submit the data to CMS. So if you could help clarify how are these two categories, CQMs, different from the QCDRs, that will be really helpful.
Katie, do you want me to take that?
I would love for you to take that, Dr. Green.
So QCDR measures are measures that qualified clinical data registries can actually submit to CMS. They go through an approval process, but the only people that can report QCDR measures in general are other QCDRs. The QCDR that self-nominated it, and if there are other QCDRs that want to report that measure, they would have to seek permission from the owner of the measure to be able to report it, and they'd have to be a QCDR. Medicare CQMs can be reported by anybody. Those are part of the 180 measures that are, well, at least proposed 180 measures that are in the program, and anybody can choose to report them, whether they're reporting on their own, in other words, submitting the data to CMS directly, whether they're using an intermediary like a registry or a QCDR. Anybody can report those. We have proposed, there were 9 measures that we proposed that were formally QCDR measures, and we proposed in discussion with the QCDR to actually have them become available to everyone to report. In other words, become CQMs. So I'm wondering if that may be where a little bit of the confusion came from.
Yeah, I think that's helpful to understand. So you're saying CQMs can be submitted by the provider organizations. And if that's the case, how are they different from the ECQMs? So we submit ECQMs and there's a QRDA format that we submit those under. Do CQMs have a certain specific format that we have to adhere to, or how is the submission process different from the ECQMs?
I can comment about the measures themselves, but this technical aspect, I think, Katie, we would need to, I'm not sure if Stephen is on or not. Katie?
Yeah, I'm just looking real quick. We can take the second piece of that back and follow up.
Okay.
So, in terms of ECQMs and CQMs, we do try to align them as close as possible, but sometimes there can be some usually minor, but sometimes even a little bit larger differences. Some of that has to do with the required timelines for ECQMs versus CQMs. If you're if you're an electronic health records company and you're programming your EHR to collect certain measures, obviously you can imagine that's going to take more than just like 6 weeks. So we do try to update the ECQMs a little bit earlier in the process, and sometimes they can be out of alignment, especially for a year or so.
Okay. Thank you so much.
Thank you.
Okay, great. Thanks. I think we had Jamie, I think had your hand up. Hang on one
Yeah,
second.
this is
There we go.
Jamie Rayner from Unity Point Health. If with the MSSP proposing to sunset the promoting interoperability requirement for calendar year 2027, will that also apply to calendar year 2026 posthumously, since it was also late in the game removed for 2025?
Can you repeat the question?
Yeah, so you talked about the promoting interoperability requirement for ACO submission under MSSP to be sunset starting with performance year 2027 in the proposed rule. It lives currently as one of the requirements for performance year 2026 submission under the MSSP ACO rules, but it had been removed late in the year last year for calendar year 2025 submission for MSSP ACO. Is there any mention of it being removed for 2026 if it is also approved to be sunset for 2027?
I'll defer to Sabrina or Erin.
Good afternoon. So the NPRM did not propose to sunset the shared savings program requirement to report MIPS promoting operability for 2026. But similar to 2025, there will be enforcement discretion for applied to 2026.
Okay, thank you.
Okay, I think Teresa Schmidt, I think had her hand up next. Hang on one second, we'll unmute you.
Good afternoon. Hi, everyone. This is Teresa Schmidt from Praxis Health Insights. And I have a question about what happens after the transition to MVPs is complete and almost everyone is using MVPs. What happens with the full quality measures inventory, the specialty sets, the QCDR measures list, and all of those improvement activities that aren't actually a part of one of the MVPs that are finalized?
Michelle, did you want to take that one? Peterman? Sorry.
I think that's something we're still thinking through and trying to figure out. That is a good point you raised, and that's definitely something that we have been considering, and we're not really sure what down the road, how we're going to be handling that. So thank you for raising that.
Yeah, thanks, Michelle. Yeah, and Teresa, that's a really good point, and feedback like that would be really helpful in the comment process related to this, our sunsetting proposal. We're definitely internally thinking through. That's why it's not, we're not saying in 2027 we're sunsetting, because we know there's some logistical things like what you're raising and some others that we're making sure we get squared away before we fully transition. So definitely would appreciate those comments and thoughts.
I appreciate the transparency in the response. Thanks so much. And I think that will be particularly important for the newly proposed measures that aren't yet part of an MVP.
Great, thanks. Okay, I think I see Jason Shropshire with your hand up.
Jason from UNC, can you hear me?
Yes, we can hear you now. Thanks.
Okay, so I have a question, a clarifying question on the 95% data completeness. Just to be clear, am I interpreting correctly that you're saying that, for example, if you had 100 ACO beneficiaries and you could exclude 5 of those beneficiaries because of a 10 issue or data issue where you couldn't get that data, so you're left with 95. Then you apply the 75% to the 95. Is that correct? Or is it 75% to the original 100?
Hi, this is Erin again. So there's a couple things. There's 2 different policies that you're describing, and the interaction is kind of the question that you have, if I'm understanding it correctly. There is a discussion of this in the proposed rule. The 95% criteria is the aggregation of the data that the ACO is submitting. the 75% data completeness is calculated off of whatever the ACO submits. So in your example,
So for simplicity, is it what I stated then? Like it is the intersection of both of those? I think that's where the confusion is coming. It's not clear how you apply those together.
So the ACO, when aggregating the quality data to submit, needs to make sure that the data reflects the TINs that account for 95% of the assigned population. Once those data are submitted, MIPS will calculate the 75% data completeness off of the data that was submitted by the ACO. So it is the 75% of the 95%, to kind of simplify it in those terms.
Great, thank you.
Can you hear
All
me?
right. Oh, yep. There we go. Okay. Yep, Amanda.
Hey, so if it's the 75% of the 95%, this is piggybacking off that question. Let's say it's an ACO that is doing ECQM collection type. So they're submitting at the ECQM collection type level. So they have one TIN that's tiny with 2 providers in it, and they are removing that TIN because that TIN has specialty EHR that doesn't program the measures or whatever. So the data they are going to submit at the ECQM collection type level represents all the rest of their TINs, and it definitely meets the 95%. Organically, by default, whoever is left, because they're submitting ECQM collection type, ECQMs or QRDA1 files, that would be 100% data completeness, right? Like the 75% report on all your numerators really wouldn't apply for an ECQM collection type because ECQMs are organically by default meeting 100% data completeness, right? Because QRDA1 files can't be manually manipulated. So as the 75% data completeness application that you're talking about, that would apply to MCQM collection types submissions and CQM collection type submissions where the data is not necessarily just QRDA1 files. Am I right?
So the ACO does not calculate data completeness. It's based, MIPS calculates that on what's submitted. And you're correct in the distinction that ECQMs by default are end-to-end and are considered to meet data completeness criteria because of that end-to-end electronic submission. Whereas the CQM reporting types or collection types, since they can be aggregated from multiple sources, that's where the 75% is relevant.
Okay, yep. That's what I thought. Thank you.
I think we'll go back to Mr. Sharma and then over to Jamie.
Thank you. So one of the questions I have is regarding MVPs. I know CMS wants to fully sunset traditional MIPS and move over to the MVP program starting 2029. My question is certain specialties, let's say oncology and very specialized, specialties like head and neck surgery and whatnot, they do not have an MVP available currently. How are we going to categorize those specialties into the MVPs if there's none available? Are we going to just find the most applicable one or find something like a primary care MVP and put those physicians there? What guidance the CMS has to this particular situation?
Yeah, I'll answer that one. This is Michelle. I would say exactly what you said. I would look at each of the MVPs and see which one is most applicable to my practice and then go from there as to what the measures are in each of the MVPs and see which one fits me best. If you're a multi-specialty practice and you've attested to being such, then you would also be expected to break down into subgroups. And so you might be able to go even more closer to your specialty if you did that, and you'd be able to find an MVP that would meet your needs. So that would be my suggestion. Thank you.
Thank you.
Hi,
This is Jamie again from UPH. Why can somebody explain why we keep creating MIPS CQMs when CMS has made it very clear they want to push electronic or digital submission of data as a whole? MIPS CQMs allow for manipulation. They're not technically digital, even though you upload a file, those sorts of things. And then along with that, in the hospitalist MVP, you talked about the advanced care planning MIPS CQM for the ambulatory space, but that is also a proposed ECQM in the hospital IQR program, which would apply to the same physicians for submission. They would just be a subset of the larger hospital population for reporting. So how does CMS work through the concept of creating measures that aren't digital? And is there any oversight into measures that cross multiple reporting programs like IQR, OQR, and QPP to help eliminate the burden of submission?
Sorry, Jamie, can you repeat the question specific about the hospitalist MVP?
Yeah, in the hospitalist MVP, there's a proposed advanced care planning measure, and it is identified right now to be a MIPS CQM in that MVP. However, under IQR, there is also a proposed advanced care planning ECQM measure. So my group in the hospitalist, they would have to submit both the MVP under a MIPS CQM and the same measure as part of the hospital that they work under for an ECQM in the future. So that's not really a reduction of burden. I would have to have two separate reports to be able to do that. So is there any conversations when these rules are proposed and these measures that overlap to make sure that you can align to reduce burden?
Well, Jamie, this is Dan Green. You know, it's not quite as linear as you described it in many instances. It may be in your practices, but advanced care plan that information is often collected, in the emergency room, by the hospital, by the nurse, perhaps on the floor, when the patient's admitted. So I would suggest that it often is not the clinician that's initially doing the reporting. Now they can check to see that the patient does have an advanced care plan and that it is, on the chart or whatever, and still participate and attest to that particular measure. But I would suggest in the hospital program, that information is often collected another way. I'm not saying it's 100%, but often collected at a different time or in another fashion.
Our advanced care planning information is collected through RegSched or the nurses like you described in both settings. A clinician from a hospital is based in the hospital, nor a clinician in the clinic space who serves as a hospitalist or who is billing hospital outpatient and therefore subject to reporting MIPS would be collecting the same thing. I mean, truly they're collecting the same thing under the same TIN, and because they're split billing Part A and Part B, they fall into both programs. So you're requiring me to collect the same data on a single patient in both the Part B billing claim and the Part A hospital side is really what's happening, at least in my experience.
Okay. I mean, I think you're, not obviously doubting you in any way. I think your experience, while not probably unique, is at least not what was intended for hospitalists. We were thinking more along the lines of hospitalists being, providers who were rendering care in the hospital, not as an outpatient.
Right. Well, they do, but our hospitalists all bill Part A and Part B, and our TIN serves as both a clinic and a hospital TIN. So you have the CCN on the hospital side, but that TIN is applied to the CCN for IQR reporting. So it comes down to essentially, I have to report, because we bill both Part A and Part B for a patient who's in the hospital, I have to report that measure twice using different collection types because the programs don't align with the collection type methodology.
Well, again, I would suggest that they do, but your case is one of the more or less common. But that, regardless of whether it's common, not common, please submit the comment to the rule, and we will certainly, try to address your comment or take it under advisement. So thank you.
Thanks, Jamie. Thanks, Dan. I think we have time for one more. I know Kim, I think, had her hand up first. So we'll go to Kim, and then we'll wrap up. But folks, if you have additional questions that we aren't able to talk through today, please reach out to our service center and we'll try to get those answered. Okay, over to Kim.
Thank you. So I didn't see anything talked about today about the ASM model and how it relates to, for example, I have a group of physicians that I work with that are in the ACO as well. So they're trying to meet the ACO measures, but they're also listed on the ASM model. Do they report both, or do they only report the ASM?
Thanks, Kim. I don't think we have anybody from our ASM team on today, unless Trevi or anybody from CMMI or CM team had anything to say on this.
Hey, no, I think we'll need our ASM folks to weigh in.
Okay, thank you.
Thanks. Okay, thanks everybody. That brings us to right at 2:30. So really appreciate everyone's time today and listening through us talk for an hour. Really appreciate the conversation and look forward to reviewing your comments through the rulemaking process. Talk to you soon. Thanks so much.